Hi, Dr. Legg and RMU clinical staff. Uh, I'd love to run a case by you on Friday regarding a patient that I had seen, an 11-year-old adolescent came in with his mother on Friday, anxiety concerns. Patient was diagnosed with anxiety 2 years ago, not on any medications. Recently living in a volatile home environment. His father has PTSD, had some issues with his job, and about a month ago started coming home from work one day, throwing a TV across the room, went into his office, demolished the office, and then came back later to apologize to everybody. So the family was a little bit shaken up, but nobody was injured or nobody was hurt. But since that episode with the father acting out, the son's now been acting out. No physical outbursts, but more verbal outbursts, mental outbursts, yelling, and anger outbursts. So mom's bringing him in to be assessed for anxiety, but she's also thinking that he's misdiagnosed and wants him a workup for ADHD and thinks he needs to be on some Adderall. So based on that information, I'll give you a little bit more about this case, but brings me to three questions. Number one, how do we carve out the ADHD focus issues from a trauma-related hypervigilance response, which is what I think is happening in this case? And then secondly, what do you think would be the best type of therapy for this patient and for his family, considering they all have a history of anxiety, and the dad's got PTSD. Mom and sister also have anxiety. And then lastly, what's the best way to pitch safer medication alternatives to the mother who is convinced that he might need Adderall for his ADHD? So those are my three situations I wanted to talk about. Differential diagnosis also came up with some of my cohorts and I. We have different takes on a few things. I wanted to bring in, of course, the F41.1 generalized anxiety disorder, but I also wanted to mention F43.21, the adjustment disorder, because it's been episodic since the PTSD outburst from his dad. So I wanted to talk about that one. And then that one can be paired with the F43.21 can be paired with Z63.8, high conflict stress in the primary support group. And then you can get therapy add-on for that, having that diagnosis code, which I think goes appropriate. Then of course we got the F90.9 and then F84.0 autistic disorder, but that's more on the back end and we're looking at rule out. Need some more information on that. So, but patient presented calm in clinic, kind of contradicting those anger outbursts at home. So there's that aspect to look into as well. No psychiatric medication trials. He's been unmedicated. He has had therapy at school before from a few minor outbursts, but nothing major. And mother said 2 to 3 sessions of school-based counseling with minimal follow-through. Got more into verbal argument with 1 or 2 of the kids, and there was a timeout. No violence. So normal developmental history, full-term birth, no complications reported. He's in 6th grade, struggles a little bit with focus and task completion, a little bit restless and fidgety, but nothing too major. Lives with both parents and the sister, average grades. He has friends, but the mom does report some social difficulties, as we talked about with the counseling. And right now, there's no current safety concerns reported at school. Okay. We talked about the family history. So my clinical impression is his inattention looks like hypervigilance, and I suspect that his meltdowns are actually an adjustment response. So, that PTSD and the episodic needs to be looked into a little bit more. Vitals labs are stable. Appearance is well groomed. Behavior is a little restless and fidgeting, nothing major. Calm, cooperative, pleasant. He answers appropriately cognitively. Mood is okay, a little bit slow to respond on the memory. His affect is a little bit guarded but appropriate. Denies suicidal or homicidal ideations, and he identifies his home life as stressful. So he does have some insight. So I think we need to avoid any stimulant in this case. I don't think Adderall is the right drug at all. And we need to target the underlying anxiety and adjustment disorder before the ADHD symptoms. So I recommend first line choice sertraline, 25 milligrams to start. And then if we're going to go down, if we need an alpha-2 agonist later, my second choice would be guanifacine. So again, the questions I wanted to bring up: how do you differentiate a primary ADHD symptoms like inattention and slow memory recall from the hypervigilance seen in this child? What type of therapy do you think would be the most beneficial? And what's the best way to pitch safer medication alternatives to a mother that's convinced that he needs Adderall? So those are my questions, and feel free to let me know how you think. Thanks.